Good afternoon. I'm Dr. Pier Antonio Russo. I am the Chief Medical Officer for Population Health Services at Spring Hills. And my colleague, Lisa Scott.
Good afternoon. I'm Lisa Scott. I'm VP of Clinical Services and Compliance for Spring Hills Senior Communities. I'm also a certified dementia practitioner. And today, Dr. Russo and I will be talking about living happy with dementia.
Thank you, Lisa. Just a quick word of introduction. Dementia really is not a disease per se, but is a word that refers to a number of symptoms and signs that are common to various diseases that are considered under the umbrella of dementia. So, for example, we have progressive diseases like Alzheimer's disease. We have patients with vascular dementia, patients with Lewy body dementia, and patients with frontotemporal dementia. There are also patients who develop early dementia in the 30s and 40s for genetic diseases like Huntington disease, and patients who develop dementia due to infection, like Creutzfeldt-Jakob disease. So, in addition, we have a number of patients who may develop symptoms of dementia as a consequence of events in the brain, like tumors, like swelling of the brain, hydrocephalus, even metabolic conditions like nutritional deficit, like vitamin B, nutrition problems. And so, again, it is a situation where various diseases cause the symptoms. And what are the symptoms? The symptoms, of course, are loss of memory. It is cognitive issues. People lose the understanding of words. They are unable to formulate the usual vocabulary. Sometimes they get lost, so they are spatial and visual confusion. And in some cases, like the frontotemporal dementia, they actually become aggressive, so they have change in behavior. And in cases like the Lewy body disease, they develop not only dementia, but also Parkinson-like conditions. So it is a heterogeneous condition with, again, several pathology underneath, and this is why it's been so difficult to treat with medicine this condition. And Lisa now will explain what can be done to manage this patient and keep them comfortable, particularly in more advanced cases.
Before I get into that, Dr. Russo, I did want to just mention about the diagnosis, because oftentimes our seniors or residents that come into our community are not officially diagnosed. They typically are provided or given a screen, sometimes called a BEMS, and sometimes use what we call a mini mental, which is more widely used. And so this is not a formal diagnosis, but this is, I mention this because it not having a diagnosis in place when they come into our community is oftentimes can be a guessing game for the staff there to decide how they're going to interact with this individual. How are they going to meet this person's need, when typically all they know is they have dementia. They don't know the types of dementia that you've just mentioned here, Lewy body. They may not know that it's frontotemporal lobe dementia. And so at Spring Hills, we put together a program, if you will, or created an environment so that not only do we try to get this diagnosis in place, but also to try to develop ways in which we can determine how we're going to interact with that individual. And that's our Spring Cottage Memory Care program.
I completely agree, Lisa. Indeed, in order to make the causal diagnosis, so what is the pathology behind this cluster of symptoms and signs, you really need to have more advanced, particularly imaging studies. Clearly MRI, but also PET scan. For example, the PET scan is an excellent way to identify patients with frontotemporal dementia, and that's important because, as you mentioned, not having the correct, more precise diagnosis may actually be not helpful at all in terms of managing these patients.
Exactly.
The patients with frontotemporal dementia need certain medications that actually the patients with Alzheimer don't need. And at the same time, if you use some of the medications that are used for Alzheimer in frontotemporal dementia, you clearly have, you may have actually deleterious effect on those patients. So certainly barriers to care and barriers to diagnosis really are a fundamental problem that still today has not been universally resolved.
Right, exactly. So one of the things, or of many, that we do at Spring Hills is to develop an environment, if you will, for our residents to live happy in. And that environment includes being positive, having a philosophy of positivity. That means every aspect of the individual's well-being in our memory care environment, in our communities, this individual is allowed to be independent as much as possible. They're allowed to engage in activities that will be positive for them so that they can have a positive experience. The persons that will interact with them are going to be well trained. And also we give what we call like tools in a tool belt, if you will, for our associates to be able to recognize a behavior, recognize a specific characteristic of this individual, and then engage with that person in that way. So, for example, we utilize a system that we call care flowers, and these care flowers each have a description of a type of behavior or something that we may see manifest in this individual with dementia. So, for example, one of our care flowers is the rose. So our caregivers and care partners are trained that roses can be strong-willed. Roses like to know who's in charge, right? And so not only do flowers bring a positive response, because who doesn't like a flower, right? Who doesn't like flowers? But it elicits a positive response from the individual that's caring for the resident. So right away, immediately, you're taking down barriers because the individual that is going to be assisting this resident, they need to come from a positive place. So now you recognize this behavior as a rose, so now you know what this rose needs in order to maybe get through their day, or maybe to be able to assist them to get a shower, or be able to assist them to meals. So taking on this philosophy of individuality and incorporating the mind, body, spirit in that, it allows the persons that work in memory care to be able to have a positive experience. Because, you know, after all, we're the ones with the fully functioning brain, right? We're the ones that can make those decisions for our residents.
What do you do for patients who have significant behavioral issues? Sometimes they have destructive behavior. Do you have any particular protocols for those patients?
Yes, absolutely. What we do for those behaviors, we track them. We recognize them. We look again in our tool belt because we're going to take a full history of that resident when they come into our community, that individual. We know their past history, and we know what their present history are. We know who their relatives are. We know who their favorite son or favorite daughter, and we use that information to elicit a positive response. We don't reach for medications. Medications are not our first option at all. We reach into our tool belt of what experiences this person have, and we jot that down like a cheat sheet to tell us, how did this person react the last time you interact with them? What was the trigger that may have elicited this behavior, from this resident? And then we try to use all those things to work around it. Now, sometimes it doesn't work. Granted, it doesn't. But medication is not our first response. We try other means before we go to medication.
Some of these patients like to move around a lot, right? They're always on the go. What do you do in that cases, in that situation? Do you have enough people who can help? Do you involve the family? Tell us a little bit about that.
Well, actually, we let them go. Actually, it's a secured unit, so it's a secured area in our community, so they're safe. We have their area, their space situated in such a way that they can move freely. That, for example, if they like to, walk around and, during meals, mealtime, oftentimes our residents can't sit still. Some of them can't. So our menus provide finger food, so they're able to do that. And there are pathways for the resident to walk freely. We don't try and stop, again, because it is a positive environment. So if we need to walk with them, we'll walk with them.
Right.
But we don't prohibit it.
What about patients who have inhibitions? They are sort of not able to interact as easy. They are withdrawn. Do you encourage them to participate in activities, or you leave them alone? What do you do with that?
Well, we kind of do both. So we create what we call work-life access attractions. And with the work-life access attractions, they mimic your home. So it may be a library area, it may be a nursery area, it may be a vanity, it can be a tool shed, it can be different areas, so that residents that have problems interacting one-on-one with others or in a group, they can gravitate toward those life work attractions and be involved, be engaged in them. Right. So that's how we try to keep them being independent, right, but also not being isolated, because isolation brings on depression. Right. And our residents with dementia also can suffer from depression.
Do you have specialists, neurologists, a psychiatrist available to your patients?
Yes, all of it. We don't, because we're in assisted living, we don't have them in-house, but we use third-party provider services that can come in and anytime it's psych. We usually have a psychiatric person available, a social worker available, especially in our post-walk communities that are 100% dementia. So third-party providers can come in at any time a service is needed.
And many patients also have other diseases, right? Other organ diseases like heart failure or coronary artery disease, hypertension. So do you have do those patients have access to medical care?
Yes, absolutely. Oddly enough, Our residents with dementia does not have as many comorbidities. I don't know why, and not on as many medication as our residents in our ALF. That might be something we need to probably look at. But they're not on a lot of medications. You may see some hypertension.
Right.
Oftentimes you don't see them with diabetes. So they don't have too many other comorbidities. But if we do have residents that have those needs, we have nurses on that's 24/7, and our staff is very well trained to take care of them.
Yeah, I would imagine patients with vascular dementia are those of the patients with cardiovascular history and diabetes history as well, metabolic diseases. But many others, as you said, don't have a history of necessarily comorbidities. They are more of a degenerative disease. It's
right.
the accumulation of certain proteins in the brain
Right.
that destroy the way the neurons work.
Right. And other organs, and especially in the case of Alzheimer's, oftentimes the person is not going to pass away from the Alzheimer's. It's going to be something else that was caused by the Alzheimer's. But one of the things I also wanted to bring up in a discussion is the importance of family, of staying connected with the family. How important that is for our residents to continue to live happy is when family members come to visit, when family members are involved in their care, when a relationship, a positive relationship is built between the family and the care partners and the nurses in that environment. I see happier residents. You see better outcomes. You don't see a lot of behaviors. You don't see that when the atmosphere is more peaceful, not rigid, right? Being a little bit more liberal, having families with the freedom to come and go. It elicits a happier individual, a happier person with dementia.
So in many of these advanced diseases, of course, at one point, inevitably there is a discussion about end of life, right? Mm-hmm. And it's always a difficult discussion for physicians and nurses to initiate, but sometimes it's inevitable. Just to conclude that any other therapy is not useful, not helpful, not keeping the patient comfortable. So how do you deal with palliative care and with hospice care?
Mm-hmm. The same way as with our other third-party providers that come in, we make it available to the families. We interact with many different hospice services, and that's explained to the families as well. It's free to choose any hospice service or even palliative care, but we welcome it. We welcome it because we want the resident and the family to have a good experience at this point, in their life and perhaps even their last days with us. So we make sure again that our staff is well trained because this is a hard topic for staff and family, right? Because it's dealing with death. So education is number one. We educate the staff to make sure that they have a good understanding and that they can relate to the family and they can include them. And so that has to be there. So we welcome hospice services and palliative care, especially for our residents with dementia.
So if a patient with dementia is on hospice, what type of medications they receive, what type of management do they receive? Well, how is that different?
Well, once hospice takes over, hospice, the company or whatever hospice, they will they will take the individual off their regular regimen of medications,
Right.
and then they will place them on medications that will keep them comfortable. So it could be morphine.
Right.
Sometimes it is not, but it could be morphine. We still like to start, low and slow and increase it. The difficulty sometimes there is that resident or that patient may not be able to tell us if they're in pain or
Right.
they're experiencing with their words, but they may be able to express it in other ways. So there definitely is going to be a comfort kit. We call it a comfort kit. And in that comfort kit, there'll be medications that will help to keep the resident comfortable.
And how many facilities Spring Hills has?
We have 20 ALFs in 5 different states. We also have 8 standalone. Of those 28 of them are standalone memory cares,
Right.
and they're in Florida, Virginia, Texas, and Nevada.
Okay. Is there any question from the public, from the audience?
Any reversible cause?
Yeah, definitely. There are some conditions with symptoms and signs that are in common with dementia. So cognitive dysfunction, inability to execute complex tasks, difficulties in complex thinking, that actually could be, in part at least, reversed by identifying the underlying cause. So think of patients who, with alcoholism who, for example, have nutritional issues, mostly vitamin B deficiency, B1, B6, B12. There are patients who cannot absorb B12, and they also start to, at one point, start to have cognitive dysfunction. So in other words, they are unable to remember, they have difficulties in articulating words, they have difficulty in concentration and solving even simple tasks. Well, the replenishment of those nutritional deficiencies with treatment that is based on both combination of better nutrition as well as drug infusion may reverse, at least in part, the symptoms. There are situations like brain tumors. Assuming that the patient is able to overcome the acute phase of the tumor, there is some improvement. There are patients who have what we call hydrocephalus. They have the swelling of the cavities inside the brain, and once that is controlled, so the reduction in the pressure inside the brain, in part that can be the symptoms and signs associated with that condition is definitely reversible. What again, at least in part, reversible.
Right. But those are typically not what we see in assisted living.
Exactly.
Communities. Once in a while we do, and those residents are typically much younger than our average resident who is 80 plus. You typically might see that individual in their 50s or 60s.
Right.
Right.
And one of the, we talked about medications. Again, we don't have good medications for any form of dementia. Clearly, there are some medications that are used to control symptoms. In various,
is that Namenda?
It is one, definitely one.
That's a popular.
Particularly in Alzheimer. But for example, that drug will not be appropriate for a frontotemporal dementia. In a frontotemporal dementia, you may need to use antidepressive.
Right.
You may need to use atypical antipsychotic. In general, patients with Alzheimer and vascular dementia would benefit more from behavioral modification than the current drugs that we have. Even the most recent drug that has been approved by the FDA has not been universally accepted because of lack of substantial evidence of effectiveness. So we are still in the search of the appropriate drug. There are vaccines under experimentation, for example, to fight the accumulation of proteins, the tau protein, into the brain in patients with Alzheimer. Also, has been discovered that the modification of one enzyme, the hypolipoprotein E gene, E-form modification in certain patients with Alzheimer's disease is in fact responsible for that disease. And so once we figure out what is the underlying cause and pathology, it would be much easier to then treat these patients.
Don't you also think, Dr. Russo, that knowing what type of dementia someone has also helps the caretaker take better care of them, because obviously frontal temporal lobe dementia is going to be different.
Yes, because those patients will have destructive behavior, they will have inhibition, they will have inability to communicate, and most importantly, they will have definitely outbursts of anger that must be controlled with a certain anticonvulsant, with a typical antipsychotic, and SSRI, antidepressant, and so on.
Right.
Those drugs are not indicated in the classic Alzheimer. Right. On the other hand, a patient with initial vascular dementia could potentially be controlled better with drugs that improve the brain circulation and the metabolic conditions like hypercholesterolemia, hyperlipidemia, that inevitably would become progressive if will have progressive consequences if not controlled.
Okay. On the clinical side, what type of behaviors should an individual, older senior, can do to maybe either hold off dementia or slow it down, aside from medications? Because I like to try other methods. So
yeah,
I'd just like to hear from
again, there has been a lot of discussions about how to prevent dementia. Unfortunately, we don't know if we can really do it, prevent dementia, particularly in degenerative conditions like Alzheimer. However, the general recommendations is to maintain active, to exercise regularly, continue to utilize your cognitive functions with hobbies or even with mental exercises. I know of a colleague, for example, that started to figure out, actually it's a psychiatrist, started to figure out that that was progressing towards initial dementia, and he started to play chess really aggressively, in a compulsive way, in order to focus concentration. Of course, diet, the general consensus is that the Mediterranean diet with the most fruit and vegetables and very and a small amount of red meat seem to be protective, at least of the cardiovascular systems, and presumably also the advancement of cognitive dysfunction. But again, these are all suggestions. We don't know exactly who is going to respond well to these recommendations
Right.
and who is going to continue to progress towards dementia regardless of these recommendations,
Right.
implementing these recommendations.
So it wouldn't hurt to try it. It wouldn't hurt to
It would not to
implement
try.
those
One
things.
of the other thing is that many, myself and many colleagues recommend is to limit the amount of sedative medications. Think of Aleve PM, for example, in patients, in older patients, because of the various consequences of depression of the cognitive function, but also potential consequences of, for example, fall, that then triggers the trauma,
Right.
brain trauma, and brain trauma can trigger then also cognitive dysfunction.
Right, exactly. So I just want to just get back to the point of living happy with dementia, and just to hone in on those things. For one is positivity, and I think the person who's interacting with the resident or the person with dementia or Alzheimer's need to maintain a positive attitude. I always say, just learn how to say yes. Say yes. You know, when you are partnering with someone with dementia, you develop almost like a dance. And you know, when you're dancing with somebody, you're happy, you're kind of trying to move with them.
Right.
So if you try to think of it that way, their interaction won't seem like, for some people, it may seem scary because they feel like perhaps they can't communicate with that person. That person is not understanding them. But in reality, it should be you, the individual, that can understand the person with
And
dementia.
create a quiet environment,
Yes.
peaceful environment.
Exactly,
Okay.
exactly. The peace, the tranquility, again, just responding in a way that maintains the person's dignity, maintain independence, maintain a relationship, which
With
is
the
something
family.
we miss.
Right.
Relationship, even to have a partner, perhaps in the community where they're living, to be engaged with someone, to have feelings for someone. That translate into happiness. It increases that the endorphins, hormone to be
Yeah.
happy. So I just want to make that point, that it's really important for us to engage in a way of positivity with these individuals. That radiates that you understand me, and I understand you.
With this, we conclude this chat on dementia and how we can manage these patients in a better way.
Yes, to live happy with dementia.
Thank you.
Thank you, Dr. Russo.
Thank you, Lisa.